Hi, my name's Ian Battersby. I'm Head of Internal Medicine at Davies Veterinary Specialists. Welcome to our second Davies Out of Hours. We're at the Live and Let Live pub just for the afternoon. I'm here with Pedro, who's head of our cardiology service. Now, Pedro's been doing lots of interventions for a number of years, doing balloon dilations for valvular problems, for example, in hearts. But some of the stuff he's been doing more recently involves interventions for cardiac arrhythmias. And today we're going to have a little bit of a chat about that. I'm an internal medic, so I don't know as much about that as what I'd like to. So Pedro, electrophysiology, do you want to give me it in a nutshell?
Yes, so basically, as you know, the heart has a natural pacemaker and conduction pathways that deliver electricity in a very specific way throughout the heart. And sometimes it goes wrong, so there are some issues, some problems that lead to cardiac arrhythmias. And these sort of procedures, the aim is to try and find out exactly what's wrong and where, so that we can maybe do something about it if we can. So it all starts with the electrophysiology study part of the procedure. That's a study where catheters introduced via the veins, normally the veins in the neck and veins in the legs. And normally we use 3 catheters at the same time. And what's done, it's really very simple, very interesting, is that each catheter is placed in a very specific position inside the heart, in touch with the muscle. And for example, one catheter can be placed close to the sinus node, so the natural pacemaker of the heart.
So that's in the atrium?
Yes, inside the right atrium. And then another catheter close to the AV node, which is the next position or point where we want to see the electricity flowing. And the one in the ventricle, for example, that would allow us to see the electricity flow from sinus node to the next stop, AV node, and then finally the ventricle. So impulse starts, electricity flows through the atria, they contract, gets delayed in the AV node, and then finally reaches the ventricles. So these catheters, we then position them in certain ways, and are seeing the actual electrical signals from inside the heart. And at the same time, we can use these catheters to deliver electricity to the heart. So we can manipulate this to then see where the electricity is going. For example, if you have a catheter in the ventricle and you start pacing the heart faster than the sinus node, so faster than the normal pacemaker of the heart, then you can follow this electricity and seeing where is it going. If it turns up in the upper chambers, in the atria, if the heart is normal, it has to go through the AV node backwards, for example. If you see it appearing in a different area of the heart first, then it means there's another pathway, for example. And that's one of the main reasons why we do these procedures. For example, that's an example of something we can then fix by destroying.
So just so I've got it in my head, because we do this under GA, don't we? So it's a theatre procedure, and you make it sound, you say it's simple, but I think you're being very humble. So you place a number of catheters in 3 different locations in the heart, and then you create, I mean, I pop my head through the theatre door, and there's like a TV screen with more ECG traces than what I can even imagine.
Yes, it's true. So depending on what type of catheters you use, for example, the machine we use, we can have up to 64 signals at the same time. So 64 lines at the same time.
And that's not simple.
No, the principle is simple. But then you don't really use all of them at the same time. You're focusing on what you want.
Individual ones. Cool.
And the position of those catheters is always changing depending on what you want to do. And there are different protocols to check function of the sinus node, function of the AV node, see if there's an accessory pathway, see if a certain arrhythmia is an ectopic arrhythmia or if it's a re-entry mechanism. So there's a lot of steps and different ways to study. So that's what makes it complicated. The principles are very simple. You're following electricity around in the heart and trying to manipulate it. But yes, when you start seeing all of those little lines at the same time and going, 300 beats per minute, it's quite...
So I guess, so once you identify where the arrhythmia is coming from, then what can you do about it? What's the next step?
So it depends. First, you need to not only find out where it's coming from, but what it is, because there are different types of possible arrhythmias.
Okay.
Some of them you cannot really test in this way. There's
Okay.
one example of arrhythmias that the mechanism doesn't make it amenable to actually triggering it, make it happen.
Okay.
So because that's what you're trying to do, you need to make it happen. So with those pacing protocols, you pace the heart in certain ways in certain locations, trying to make the arrhythmia start.
Oh, okay.
Okay,
Yeah,
and then you try to make it stop.
Okay.
The way it starts and the way it stops gives you clues as to what's the underlying mechanism.
Right.
Okay, how many problems there are, because you may have problems in more than one area of the heart, and then you need to find one and then destroy it, and then find the other one and destroy it, and so on.
And when you say destroy, that's ablating it, is it?
Yes.
So that's with heat, I presume? Okay.
So there are different forms of ablation.
Yeah.
You can use heat, you can use cold, cryoablation, you can use other ways, ultrasound, etc. The one we use is
with heat.
Is heat, yes. So the tip of the catheter, the ablation catheter, causes very intense heat, very localized, and basically burns that area of muscle.
Okay. And then I presume are there certain types of arrhythmia that are more, well, not easy, because it's not an easy thing to do, more amenable to this kind of thing, and some that you can't use this procedure on?
Yes, and then there are also some that are easier than others.
Okay.
Basically, you can use the study to identify pretty much any sort of arrhythmia. So you can use the study to know what's happening and where it is located, or roughly where it is.
Okay.
You can even use the study to test normal function of the structures, you know, the sinus node and the AV node. You can see if they're working properly or not.
Okay.
And they do all of this in people. They do a lot more than we do currently, and hopefully we'll do more and more in the coming years.
Okay.
Yes, there some, for example, in our cases, we mostly use it for tachyarrhythmias, so fast heart rates coming from the upper chambers.
Okay.
So from the atrial tachycardias or supraventricular tachycardias. The reason why we do this is because they're more likely to be easy to fix, or easy, not really easy, but and safe. Because if you're then dealing with ventricular arrhythmias, the risks are much higher. You know, you can, and we do have that sometimes with dogs, even with atrial rhythms, we can trigger fibrillation, and we need to defibrillate. So the risk, especially with ventricular arrhythmias, is higher. You can end up with ventricular fibrillation, the patient dies, unless you can defibrillate successfully, which normally we can. These procedures are very safe because they're very controlled. We have all the drugs ready, we have everything ready, but the risk is much higher if it's ventricular. The other issue is, if you think about the heart, the muscle has a thickness. And the catheters are inside the heart, but the impulse may come, the abnormal impulse, if you're thinking of ventricular rhythms, you have an ectopic rhythm, it can be on the other side, it can be on the epicardial side. So you cannot burn all the way through till the other side, because you end up with a hole and a leak. It's not ideal. So if you do a study for ventricular rhythm and you end up realizing actually it's not on this side of the heart, it's on that side, then you'd have to open the chest, go with the catheters on the other side, find it and destroy it. That's not very practical.
Because
these procedures are very expensive. So we really need to be careful with what we can achieve.
So I guess a lot of these cases, I mean, I suppose the first thing to say is not all cases are suitable for this, and they need would you say a detailed assessment, or?
Yes. So for example, with going back to the atrial rhythms that we normally deal with, there's three main examples of things that we normally do. Ectopic atrial rhythms, so basically one little area of muscle that has suffered damage for some reason and is now able to act as a pacemaker, and it's going very quickly. So imagine just a tiny little area of muscle inside the atria. So that we try to find out exactly where it is and we burn it. And because the muscle in the atria is much thinner, the likelihood of not being able to damage it is lower because you can hit. But of course, you need to be careful. You also don't want to burn all the way through. And that's why the success rate in those cases is not always 100% because it may not be feasible. You may not be able to safely do it. Also, it can be quite difficult to find a tiny little area in the muscle inside the heart blindly because we're doing all this blind. In humans, they have, and hopefully we will have someday, but they have 3D mapping systems that basically create a 3D reconstruction of the inside of the heart.
Wow.
So you can actually see where your catheter is going, is now and has been, and where you've delivered energy. So that makes things a lot easier. It will make it a lot easier for me to do it. The way we do it is the way they used to do it in humans, and they still do in many cases, but we're basically doing it blind with fluoroscopy, which is real-time X-rays. So we only have two dimensions
in a 3D space.
And we're just moving the catheter around and seeing the change in electrical signals until we find what we're looking for. So that's the difficult part. The principle is simple, but then
the difficult bit is doing it.
So that's an example of something you can fix. Another, which is the most common use for these procedures because the rate of success is quite good, 90 to 100% in that case, is accessory pathways. So accessory pathways are extra pathways that allow passage of electricity from the upper chambers to the lower chambers. And they are located along the valves, the annulus of the valves, because that area of the heart is just fibrous tissue. There's not supposed to be any muscle, any connection from the muscle of the atria and the muscle of the ventricles. The only connection that should be there is the AV node. So that makes it easier because if you imagine both the tricuspid and the mitral annulus, you're going with a catheter all around it until you find where the problem is. So there are always exceptions. Sometimes they're a little bit off that area, but mostly that's what happens. So it's much easier to find.
I can see that.
And it's much easier, and it's safer as well to ablate in that area because you're not ablating towards the outside of the heart. You're actually inside the heart, ablating a fibrous tissue area. In a
defined area that you can locate a lot easier.
So those are the accessory pathways. Or in humans, they commonly use the term Wolff, Parkinson, White, to mention the people that found this problem. And the third most common application in our patients is atrial flutter, a macro reentrant circuit normally inside the right atrium. So electricity is flowing along the wall in a loop, along the inside of the wall of the atrium, and basically you go in a certain specific area and you just burn a line, so that when the electricity gets there, it cannot go through.
And just because I'm obviously not experienced in this, is it a long line? Is it is it a line that could potentially a pathway form around?
So that's the difficulty, and that's also why the results are not 100%. Because imagine you have a moving heart, and dogs can have a very fast heart rate. So the heart is contracting, your catheter is inside moving with the heart, and you're burning a line. So you can imagine it's not going to be a perfect line. It's going to be a wiggly line. And if there's a little gap, the electricity might find a way through. So you may have a recurrence. So for example, with that type of procedure, the results are normally between 70 to 100% success. So in other words, in 30% of the cases, you may end up having a recurrence. So the problem is still there. You haven't been able to fix it completely.
So, we just went over a little bit about how there's the challenges with the ventricular arrhythmias. Do you think that's something that's achievable for the veterinary? Veterinary market? Or?
Yes. So it's possible, and if the right case comes along, we would be happy to do it. We just need to set our expectations. The right level. So, for example, dogs with certain disease, arrhythmogenic right ventricular cardiomyopathy, so boxers, English bulldogs, that have or that we have an idea where the problem might be. For example, with English bulldogs, sometimes it's right before the pulmonary artery in the outflow tract.
Okay.
So there are some possible cases that could, as long as the the client's, the pet owner is aware of, we might not be able to do it, and there is some risk.
Some risk involved.
Yes. Yeah. The benefits, if the procedure is successful, could be quite high. I mean, that some of these dogs don't respond to antiarrhythmic treatment, and they're really poorly, and they end up dying from, or are at risk of sudden death. So there's definitely potential to massively benefit from these procedures.
And I guess
the issue is, and hopefully this will improve over time, is cost. Because in humans, you have this procedure done. If it fails, they just do it again. Yeah. No one is worrying about costs. I mean, maybe the Prime Minister, or maybe not. But with us, if we do this procedure and we spend all that money in one procedure and it fails, and we can't just say we'll do it again. Don't worry.
Yeah, because of all the.
So that's the main.
And I guess just coming back to something you talked about a little bit earlier, you understandably get requests for this procedure, because from what my word, there's very few centres in the world that do this procedure.
So this is quite it's quite difficult to set up this sort of procedure. It's quite difficult to reach the right level of experience and knowledge to be able to do it. And for that reason, we have help from human specialists that come and do this with us as often as possible. I have done it by myself, but the cases I've done it by myself, I really didn't have a choice. They were very poorly, they were dying. The human specialist was not available at short notice, so it's either that or nothing. So I was able to do it, fortunately, with success, and I'm very pleased with that. But the truth is, this is quite difficult. In humans, they train for 4 years. Every day, this is their job. They are supervised doing these procedures in humans until they start doing it by themselves. So it's a specialty of cardiology in human medicine.
A subspecialty of a specialty.
So in veterinary medicine, there's only very few centres, I believe 3 or 4 centres in the whole world doing this, and we're one of them.
Absolutely, which is
quite happy.
A reflection of how brilliant you are at your job, Pedro. You're very modest. But I guess just coming back to again the patients. Some of the you mentioned patients where it was like life or death, and we had to move it forward. With the heart beating excessively quick and they're not responding to antiarrhythmic drugs, that starts to cause heart problems. So what kind of patients?
The main issue at the moment is, because these procedures are not well known at all, and there are only very few centres offering these sort of procedure. Most people are not aware of it. Vets and pet owners, they don't know this exists, and we don't know we have these options. So I'm pretty sure many cases still don't have, this is not offered to them, and they end up dying from these problems, when actually they could maybe be even cured. Some of these procedures, we can actually cure them, and they're normal, completely normal. So unfortunately, many of our cases are very poorly by the time they get to us, because they've already been on one medication, 2, 3, 4, nothing works. Their hearts, if you make a heart go too quickly for too long, the muscle just becomes damaged and fails. If tomorrow I decide to run the London Marathon and I don't train, my muscles will be very damaged, and I won't be able to get up the following day. So it's the same sort of principle. So unfortunately, every year we have a number of cases that they are so poorly when they come to us, like the ones that I had to do by myself, that they either don't survive long enough for us to be able to perform the procedure, or they don't recover after the procedure. Meaning that the procedure is successful, the arrhythmia is gone, they're much better than what they were before, but the muscle is so damaged that the heart remains enlarged and weak, and yes, we can still help them with drugs, but if we had done it 6 months before or so, they would be normal dogs. And that's
frustrating.
That's the issue at the moment, is educating colleagues and everyone.
Colleagues, public,
Yeah.
And I guess just to summarise then, I mean, you know, if a dog has an arrhythmia, you know, options are, you know, for it to go on medication, and if it doesn't respond to medication, this is an option. But I guess these patients could also have it instead of medication, lifelong medication. And then, you know, would you say, I mean, how would you say if, you know, if a primary vet diagnosed an arrhythmia in a dog, how would you say would be the best way for them to go about getting the dog assessed to consider whether it is suitable for ablation?
Before I answer that, I think if we look in what's happening in humans,
Yeah.
the advent of these procedures change things. So
Okay.
for humans, a lot of these arrhythmias, intervention is the first line treatment.
Yeah.
So not drugs. Unless you don't want to have the procedure, you prefer to have drugs, they would often recommend these studies and these procedures as first line treatment.
Okay.
So it's the other way around.
Yeah.
We try a drug doesn't work, we try another drug, doesn't work, we try combinations of drugs, and they don't work, and then that's when they come to the procedure. So for vets to be able to access this, very easy. There's an arrhythmia, especially very fast, so tachyarrhythmias, fast heart rates. An electrocardiogram is the starting point, and it's very easy to have a cardiologist opinion on an ECG. You know, there are many different services that offer interpretation of ECGs online. We do the same. Well, a lot of our referral vets just send us an ECG. Sometimes they call, sometimes they just email, send us an ECG. We look at it, we interpret it, say this is what's happening. And we already know the type of cases that might be
Suitable.
strong candidates. But like it happens in humans, you feel there's a problem, you go to your doctor.
Well, you could go to your vet if you wanted.
You go to your GP doctor. They send you to a cardiologist. Well, they ask for an ECG, and then you go and see a cardiologist. And then the heart needs to be assessed from the structural point of view, because the arrhythmias may be the primary problem, but often they're a consequence of a structural problem.
Okay.
So you have heart muscle disease. You have inflammation of your heart muscle, you have anything that went wrong with your heart structurally that then causes damage, and then the arrhythmia happens.
Okay, that makes sense.
On the other hand, you can, for example, accessory pathways, it's a malformation, you're born with it. It shouldn't be like that, your heart is just not formed properly. And so the arrhythmia is the primary problem, and then that may lead to structural problems. From the practical point of view, it means you're gonna see a cardiologist, you're going to have electrocardiogram, a heart scan, and the Holter monitor, which is an electrocardiogram that basically lasts for 24 hours at least. And that's what's going to tell us how frequent is the arrhythmia, how fast is your heart going when you're having these periods, and what's the average heart rate. Is it too high? Is it going to cause damage to the heart muscle? Okay, and then most of these cases would then go on to drugs, because sometimes drugs work. Depending on what the problem is, sometimes drugs work for a while, 1-2 years, maybe more, and then they stop working, and then you still need intervention. So it really depends on what's the problem and how it's...
So it's a case-by-case assessment, basically. Okay, cool.
But it shouldn't be difficult at all, because electrocardiogram, everyone has it, or should have it, but I think everyone has it. Send it to a cardiologist, and the cardiologist would recommend. And you know, we get advice requests from vets and veterinary cardiologists all the time. We speak to each other. Just because we're specialists doesn't mean we know everything.
No, absolutely.
So,
absolutely. Cool, man. Cool. Well, thank you very much.
Welcome.
Really nice summary. It certainly improved my knowledge of it quite considerably. And hopefully you found that useful, and we'll produce another Davies Out of Hours soon.